Hello, and welcome to today's McMaster University Continuing Education Caregiving Essentials webinar. Let the revolution begin, supporting patients and families differently. I would like to begin by acknowledging the land on which we reside. McMaster University recognizes and acknowledges that it is located on the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. My name is Jennifer, and I'll be your host on behalf of McMaster Continuing Education. Today, I am joined by our facilitators, Donna Thompson and Dr. Samantha Winemaker, as well as Liv Testoni, our marketing specialist. I'd like to introduce Donna Thompson. Donna is a caregiver, author, and educator. She's the author of 2 best-selling books on caregiving, including The Unexpected Journey of Caring. Donna also facilitates our free online for caregivers, Caregiving Essentials, and she is a co-designer and co-instructor of the Family Engagement and Research course, both here at McMaster. And I'd like to introduce you to Dr. Samantha Winemaker. Dr. Winemaker is a graduate of McMaster University Medical School. She has completed residency training in family medicine and fellowship training in palliative medicine. She's an associate clinical professor at McMaster University in the Department of Family Medicine, Division of Palliative Care. She is the co-host of the Waiting Room Revolution podcast, active educator, researcher, author, and advocate for palliative care reform. Donna, I'll hand things over to you.
Oh, thank you so much, Jen. I am so excited to be talking to you, Sammy. I'm going to call you Sammy.
Please do.
Yes, because as I mentioned before, this is a really casual conversation about things that really interest us and things that really matter to us. I want to say in your description that Jen just read, I want to add, you are an Instagram star and influencer. Your online education about caring for people with critical illness is so extraordinary. It's so uplifting. It seems like an oxymoron to say palliative care, public education for clinicians, for families, for patients could be uplifting, but it is. It inspires me every day. And I want to ask you, first of all, palliative care is a space that we've been in my family a number of times with various family members. And I've always found it to be a place of great comfort and a place and a space in clinical medicine where we all felt truly cared for. So I want to ask you, though, what brought you to palliative care, Sammy? Who is Sammy Winemaker? And what brought you to palliative care when so many other areas of medicine get very uncomfortable if a patient cannot be cured in a hurry? You kind of become persona non grata in the hospital if you have something that's incurable. So what the heck? How did you get into this?
Yeah, had you asked me when I was a teenager or said to me, you know what, I have this crystal ball and one day you're going to be a palliative care doctor, I would have said, I think you have the wrong person. But I think what happened to me is what I see with the residents and the medical learners when they come and do a rotation in palliative care. I had the same experience. When I was training, I you have to do mandatory rotations in internal medicine. And if any of your listeners or viewers are internal medicine clinicians, I'm just sorry to say this, but I honestly did not want to do another rotation in internal medicine where I felt that the patients, for the most part, were reduced to an organ or an illness or a bed number. The goal was to get them out of the hospital as fast as possible with no malintention, but it just it didn't feel like the reason why I went into medicine. And so I avoided internal medicine, and it was the first year that they offered this thing called a selective, where you could pick from a number of experiences. And there was orthopedic surgery. No, I wasn't going to pick that. There was, neurosurgery. And there was this thing called palliative care. I thought, okay, I'll do that because I'm not doing any of the rest. And so I did a rotation in palliative care and suddenly felt like I arrived home. That it, for me, reminded me of why I ever wanted to be a doctor. I was so inspired. I was humbled. I was amazed at the patients, at the families, the care providers. Everything felt right to me. It was like a huge aha moment. And like I said, residents, when they come and spend time with us in palliative care, they have the same experience. They all fall in love with it because it reminds them of why they applied to medical school. But in their training, somewhere along the way, they lost it and then come back to it when they just happen upon palliative care. It's a really rewarding area of medicine where when everyone else is running for the hills, we lean in and we stick with it, and we companion journey alongside people. And there's nothing more people can do, we do, or we just stay or listen. It's so raw. It's so not sophisticated. It's not sexy. It is so real. And it feels so good. Even when you can't fix an illness, you can fix or help the experience of the illness. And that's so powerful. So it also is rewarding and makes you think about your own life and your own relationships and your own fears and anxieties. And I'm constantly thinking about, what would I do in that person's situation? Would I be as strong, as brave? Would I be able to do it? And I think not only myself, but my family has benefited vicariously just from me bringing home just very inspiring, real, honest scenarios, confidentially. I mean, I don't talk about the patients and families, but
No.
It's just brought the taboo into view for us. And it's a huge relief to burst that bubble of pretending like we're not going to die. Every single one of us is going to die. And I personally am not scared. I'm not ready. I don't want to die right now, but I know I will one day, and I'm not scared. And if you ask my two daughters, I don't think they're scared either. They don't want to die. They don't want me to die. I don't think my husband, none of us are scared. So it allows us to live our lives, I think, without those fears. I wouldn't say, oh, we smell the roses and everything is great in the winemaker home. No, that's not the case. But we don't operate through this lens of denial, I guess I would say. So for all those reasons, I just think palliative care should be part of the practice of all healthcare providers, no matter what area you focus in, because it is, at the end of the day, just good medicine. It's good care. It's person-centered. It's being able to balance hope and reality. And so why it needs to be a specialty, I don't know. But anyway, that's the long.
Well, it's so interesting. It seems to be one of the only areas of medical care where love and acceptance and spirituality of any kind are allowed and actually celebrated and supported. So, there are a lot of questions already in the chat, and I'm reading them, and we are going to come right back to those questions in a minute. But Sammy, I'd like to, before we get to the questions, I would like you to tell us about the tenets of that you developed with Dr. Cian Ciao, who has been a guest on our Caregiving Essentials webinar before. And when you came together with Cian and created the Waiting Room Revolution podcast, you, with Cian, determined a number of what would you call them? Guideposts of how to survive this experience, metaphorically speaking, and come and go through an end of life or even a critical illness diagnosis the best way you can. So can you tell us about that?
So, I think that's the good news. So I like to tell people that really I'm an end of life care specialist. Let's call a spade a spade. It shouldn't be that way, but that's where I end up working in that space. When people have a progressive life-limiting illness, usually they would see someone like me at the end. And when you are caring for thousands and thousands of people at the end, you begin to really pay attention to trends and patterns. And for myself and for Cian as a researcher in palliative care, there were certain themes that just kept bubbling up that made the end worse or the end better. And so it became very clear to us that there were patterns that would lead people down a rocky road and patterns that would lead people down to a better road. And so what we did was we deconstructed all of that end of life intel. And we said to each other, don't you think that patients and families deserve to have this information at the beginning of their illness journey? Why should they wait to the end to have these moments that we have something to share here? These people's stories might not be able to change, but certainly we can offer information and nuance it in a way we're not selling death and dying at the beginning of an illness, because for many illnesses, that won't be the end. But there's definitely these patterns or keys or skills that people could know about, not just stumble upon, they could know about at the beginning so that they had a fighting chance to stay more in control through their illness journey, know how to ebb and flow, feel more anchored, feel like themselves, feel invited to their own illness journey, not get so lost and scared and fearful because we're going to tell them the secrets of feeling like you're in the front seat of your journey. And so we came up with 7 skills or keys is what we call them. And basically it is really about being able to be hopeful and positive while at the same time being able to ask important questions about the what ifs. So I see you have them up there now, the 7 keys. Thanks, Donna. The first key is walk 2 roads. So we help people understand that where it's really great to be positive and be cheerleaders for each other, that we can't only walk that road. We have to also ask ourselves, what if the treatment doesn't work? What if I need to make a different decision? What if things go sideways? So we explain to people that learning the skill of walking 2 roads is the healthiest way to go through an illness journey. Always finding something to be hopeful about, but also seeking the truth and reality and extracting it from the healthcare system so that you can always have your hope match where you're at in your illness journey. So that's what we call walking 2 roads.
And that's hard to do.
That is so
because that's not something usually patients and families are offered.
No, they're not offered. And in fact, we get the opposite. The tendency, human nature, is to say, oh, come on, Donna, you can do it. Donna, you look so good today. You know what, Donna? Don't go there, Donna. You have to be positive, Donna. Stiff upper lip, Donna. You can do this battle. Come on, you got to fight, fight, fight. And so we bring on this toxic positivity with good intentions. Family do it, neighbors do it. We do it to each other. Healthcare providers do it because we're uncomfortable when we don't know what else, right? So it is difficult. So we teach people how to extract the other road from the healthcare system. And then the next key is zoom out. Zoom out is really teaching patients and families how to get out of the trees and rise up and see the forest of their illness journey. Or the tendency is to walk through an illness journey like in a maze where the hedges are so high, you can't see where you're going to turn right or left or a dead end. You can't see the end at all. You can't even see where you're at in the maze. And so that skill is about learning how to get yourself above the maze, looking down on it, your illness journey, and to get a better sense of what that illness looks like from a big picture perspective, that it has chapters. And which chapter are you in? What does the next chapter look like? And how to look long into the illness instead of just being day to day, which is the tendency for healthcare providers, is to stay in the day and deal with the daily, and families are dealing with the issues of the day. But if you always are in a day to day in the rabbit holes, you never really get the perspective of the big picture. So that one's about looking at the big picture.
Can you tell us just one, I know you in your public education that you do on social media so well. There is, you often say, if your doctor tells you they don't have a crystal ball
Oh, I hate
and
that.
won't give you the information you need about where you are in your illness journey, in those chapters, as you say, what is something a patient or family could say?
So this is why we started this social movement, right? So I'm just going to look there. There's 135 participants. And let's say we can get this message out to millions of people, that we have a new type of patient and family that are going to come to the healthcare system. So it's not just Donna asking the doctor and not getting the information she needs, that if we can create a wave of newly skilled patients and families, and they're asking the same questions, there'll be no tolerance for responses like, oh, we don't have to go there, or now, we'll talk about that when we need to, or I don't have a crystal ball. We do have a crystal ball. We know what these illnesses look like, okay? I know what Parkinson's looks like in every chapter, ALS, multiple sclerosis, dementia, all types of dementia. I know what non-curable cancers, COPD, pulmonary fibrosis, ALS. I could go on and on, heart failure. Millions of people have had these illnesses. And so we in healthcare know how they behave. We do have a crystal ball. We can tell you what the pattern of these illnesses looks like over time. And when you know, how do you know you're in the next chapter? How do you know when you're in the advanced stage? How do you know when you've entered the terminal stage? We have these general population statistics around the average life expectancy for someone with these illnesses. Now, that doesn't tell you, Donna, what your timeline is, or you, Donna, exactly how you're going to have, for example, Parkinson's or whatever, but it can give a patient and caregivers and families a general roadmap. And so what would you say to the doctor who says, I'm sorry, I don't have a crystal ball? I know what I would say, but I would encourage people to know that there is intel in the crystal ball. And you could say to the doctor or healthcare provider, Okay, I appreciate that you don't know exactly maybe what my storyline is going to look like, but I know that you've cared for lots and lots of people with this particular illness. I'll just say doctor. And the reason why my family wants to know this information is because we're really trying to plan ahead, and it would be very meaningful. And guess what, doctor? We want you to just be straight up. You have permission from us to speak frankly. You don't have to sugarcoat it. Don't worry about making us upset. Information is power to us. And so I know people aren't going to say that, but that is the kind of response I want people to say to the doctor or nurse who says we don't have a crystal ball. I'd say, you mean you've never cared for someone with heart failure before, doctor? You're a cardiologist.
Mhm.
Sure, you can tell me what this is going to look like, doctor.
Yeah.
It's just that we behave so, we just behave as patients and families. We behave too well, actually.
That's why the name of the podcast includes the word revolution.
Yeah.
Yay, we want a revolution. I want to pause just for a sec because we want to go through all of the keys. How do palliative and hospice care differ?
Oh, okay. So it really does depend if you are from the US or from Canada. So I'll speak to Canada. So hospice in Canada is a bricks and mortar place of care. It is a place where people go, typically in the last months of life, where they can be cared for to die. Okay, it's bricks and mortar. It's a care setting. Now, those hospices often have other programs that they offer in the bricks and mortar. They usually have anywhere from 6 to 10 rooms where people can go in that community to die, but they usually have a healthy volunteer program. They can have other social day hospice programs. They can do education, but it is a care setting. Palliative care, if you ask me, is a philosophy of care. It is a philosophy of care that all healthcare providers should learn and should be able to pepper into their skill naturally and seamlessly along the entire illness journey. That's what I think. But right now, palliative care is really two things. It is a specialty. It is a specialty of care providers who know how to care for people with progressive life-limiting illness. And they are invited into the illness journey by other care providers to provide consultation for pain and symptom management issues, or information or complex discussions, goals of care discussions. So it's a specialty usually made up of doctors and nurses and psychosocial, spiritual clinicians, navigators, and they are like a specialty team. And depending on where you are in Canada, that specialty team can work in hospitals, can work doing home visits, can work in long-term care, retirement homes. They can work in the hospices as well. So it's a specialty type of care. But in the last decades, we're also trying to sell it as an approach to care as well. Like I said, a philosophy of care, that you shouldn't have to be a palliative care specialist like myself, that this palliative care approach should be part of the skill set of all healthcare providers, so that a patient and family shouldn't even have to ask for palliative care. They should just be getting it naturally because the clinicians know how to dance across different philosophies of care, curative care and disease management with palliative care as the illness changes over time. So the hospice is a bricks and mortar place, but palliative care is a philosophy, an approach, and a specialty.
And just quickly, before we return to the keys, which I really want to do, it differs, again, region to region as well, doesn't it? In terms of that team approach. This is a comment from Lara in the chat that it doesn't always look like what you're describing, even though they say, oh, you are now on palliative care.
Yeah. So okay, I would say across Canada, we still have areas in Canada that do not have access to palliative care
Mhm.
as a specialty, and nor do we do a good job teaching in nursing school or medical school how to provide palliative care. So we do still have inequities and access issues across Canada for sure.
Yeah, absolutely. So going back to the keys. So what's the next one now?
The next one was know your style. So really, that one is about there is a lot to harness about each and every one of us as an individual that we ignore as we're going through the busyness of an illness. We forget who we are. We forget the type of natural coping mechanisms that we have used in the past when we have faced difficult situations. All of us, we have natural personalities, natural vibe, natural mojo, natural skills that we have used or not used as we've faced difficult situations. And, that's hugely powerful for better or worse. Some of our coping mechanisms or our styles haven't served us well. Some of them have. But this is about really looking yourself in the mirror. We try to help people understand and predict how they're going to fare, how they're going to behave, how they're going to react when they have a progressive life-limiting illness, because you die as you live. The way
Mhm.
in your entire life, you will bring that to the table when you're facing a progressive illness. So if I tend to dig my head in the sand, or if I'm a super seeker of information, or if I shy away from things, or if I'm disorganized, all of these different styles will have an impact. And so we help people take stock of their style and predict, how is that going to serve you? Or how is that going to make it naturally more difficult for you? And then it's sort of like a dating service. If Donna's really organized and I realize I'm not organized, I'm going to hook up with Donna, who's in my inner crew, my family. So we talk about your own style, and then naming the people that are in your inner circle and what's their style. And we match and we extract and create a team around the person so that you have all the qualities you need as a crew to get through this.
Mhm. It's so interesting because this approach is the same approach as creating networks of personal support in the disability world, where you have this idea of a crew. I love that word. And it also makes me think of being in a boat. You know, there are so many great analogies for feeling like you're out there alone. Does anybody know we're here? Who is the captain of this boat? Are people swimming alongside the boat? Is anybody drowning? All of these visual images that seem very appropriate for this very difficult experience that, as you say, calls upon us to be our true selves and to look ourselves in the mirror without any artifacts or pretense, and being very realistic about who we are, what our strengths and what our strengths are, in areas that we just don't want to go with, because I think there are lots of patients who don't want to know. My mother was one. And I don't think my father probably wanted to know either when he had 3 strokes. A lot of people are very much in the business of propping up some fiction of denial. And I guess what you're saying is that if the whole family goes along with that, props it up, it just ends in regret, right? Somebody's got to know the truth. Somebody.
because you can't hide it forever. And
Yeah.
then I so many people at the very 11th hour say, really, you're kidding me. I wish I would have known. I would have done something differently. I would have made a different decision. We would have spent our time differently. So denial in the end, if everyone's in it, ends up biting you in the butt, really.
Yeah.
And so, yeah, if I can find at least one person in the crew who's willing to look at the reality of the situation, then I feel, okay, this crew has got someone with their blinders off. So we really try to find at least one person who's willing to go there, to look long into the illness, and from above look down.
Yes, yes. In a minute, I want to get to a question we had about when someone who is palliative has a cognitive impairment or a communication disorder that makes understanding their own situation difficult. But let's continue for now, just because I want everybody to have the benefit of this great wisdom.
The fourth one is connect the dots. So it became very, very clear that the families in the end who did better had someone in their crew, if not themselves, that realized that becoming the manager of the informal care was really important. So that we just call out the fact that the healthcare system is imperfect. It is not slick. It's not completely connected, all the pieces, and there is a necessity for the patient or family or someone to realize right from the beginning that we have to stay organized here. We need to almost be the carrier pigeons from one puddle to the next, or one I shouldn't say puddle, one care setting to the next, bringing information and intel from the experience from the home, and also making sure that you are documenting in the easiest way possible all the different milestones or bus stops along the way, all the important information, like you're almost keeping your own CV or resume, a binder people talk about. There's lots of different ways to do this, but you almost have to, and it shouldn't be this way, but you almost have to have your own care coordinator or navigator within your informal crew or the patient themselves. So again, you naturally seek to appoint someone or ask someone in your crew to be the person who's going to help connect the dots.
Yes.
Yeah.
So I wanted to just ask you, Sammy, what do you think about death doulas and the role of this is something new in palliative care, and I know someone who does this work, who walks hand in hand and death cafes where people, anybody like you and me, healthy young people, no diagnosis, can go and talk and reflect on what kind of a death experience they want and what kind of support, and begin to plan for it. I think this is something we should all have access to.
Yeah, I mean, until we can ensure that we can, that we can teach or offer patients and families themselves how to be their own doulas.
Mhm.
People don't have a crew, right? Some people walk their journey by themselves. So I think the death doulas are filling a gap right now. And like I said, I'm a palliative care specialist. I hope in 2 decades, we won't need a palliative care specialist because we'll just naturally do it so well in healthcare. And same with the death doulas. They are filling an important gap right now. And hopefully we won't need them in decades also, when patients and families can be more, I'm not sure people like the word empowered, but in the know, So
Mm.
I think the death doulas are going to have a hard time marketing with their, just like we have a hard time marketing palliative. It's a 4-letter word. And so, we know people don't want to talk about it. There's always this discussion about, should we change the name or should we just call it like it is? And the death doulas have decided to just call it like it is, the death cafes, the death doulas. Really, it's about dying though. And it's interesting because people always talk about death education, death awareness, death doulas. Death is after. It's when you're dead. It's dying that we need to talk about. No
Yes.
one's talking about dying, and dying is a distinct stage of life that no one escapes. It's as normal as menopause, puberty, birth, adolescence. Dying happens over a period of time, not a light switch. It's not, death happens when you stop breathing, but dying usually starts months before you're dead, unless you're struck by lightning. But so I think all of these death doulas and the death cafes are super important. I think that you shouldn't have to pay for them. Obviously, if they're filling a necessary gap in the healthcare system, then they should be available to everyone.
Mhm. Mhm. Well, I can't actually read the graphic, probably because of my name, but I think we've one more key. Do we? One or two more?
We have 3 more keys, but I don't have to belabor them. The next one was anticipate the ripple effects. So that one was just about the fact that a patient gets the diagnosis and they become the star of that illness. They get all the spotlight, and often in the shadows, we have other people that are affected by the illness. They end up having their own illness journey as a family member or caregiver, and they also become very important in the person's illness. So it's really just saying you are not in this alone, but in a way that broadens the spotlight that an illness is a family affair. It's not an individual affair. And we need to make sure that we broaden the spotlight on those people, or else we end up with more than one ill person. And so, like you've talked about, Donna, so many times, people stumble into the role of caregiver or stumble in, they become, ignored, invisible. They just become someone who drives the person to the appointments. But you and I both know there's so much more than that. And so it's, again, bringing them to the front stage.
Yeah. The other thing is that many people, I think, another podcast or another webinar that we had talked about PTSD and trauma in family caregiving. And, there are a lot of people who are isolated at home looking after someone with a life-limiting disease and right through to end of life. And without the benefit of these 7 keys, without the benefit of the kinds of community supports that we need, many people are left traumatized by this experience. And I wonder if you can talk a little bit about, in order to minimize the trauma, in order to do some of the myth busting about end of life that you do so well, when should people begin to be told or investigate for themselves these 7 keys and begin to put them into practice by talking about them with each other in families? What does that look like? I wonder if trauma is sometimes because we wait too long to implement these strategies.
You're so right, Donna. I mean, I can't begin to tell you how many times I'm called for symptom issues, pain, insomnia, nausea, headaches. And if you peel back what's really happening, often a person is dealing with trauma from the system or anxiety, being in the dark, being scared and fearful. And so we don't need to be that way if we start our journey with these kinds of skills. These skills, which are in our book, are not about dying. It's not about death. It is about the best illness experience you can possibly have so that you feel intact the entire way. You feel like a human. You feel like you make decisions that are best for you, not just yes, yes, yes to everything that comes your way. So the trauma will be mitigated or assuaged if people start their journey eyes wide open. And it's not about talking about death and dying right at the beginning of the diagnosis. That's not our goal. Our goal is that these 7 skills will help people along the entire illness. And by the way, the dying and death part will be way less traumatic because you've done this early on. So as early as possible, people should be learning this stuff, because what we've done is peeled back the curtains on what isn't talked about in healthcare. All the landmines that patients and families step on, we have come up with what we hope is a palatable solution for patients and families that's not scary.
Yeah. Maybe you can tell us a little bit about your book. And I'm just so thrilled to say that we have a couple of copies of your book and a couple of copies of The Unexpected Journey of Caring as well, that we're going to be giving away to randomly chosen members here this webinar today. So tell us about the book and what your hopes and dreams and how people can access it and everything.
First of all, I love your book, Donna. I have a copy of it, so you don't have to give me a free copy. I
Thank you.
recommend it to so many people. Our book, which is called Hope for the Best, Plan for the Rest. It's about the 7 skills that you need to have a better illness experience. It is the culmination of, everything we've learned from caring for people who have had a rocky road and those that have had a smooth road. And like I said at the beginning, we have reconstructed it into chapters that will help people feel like, as I mentioned, more control, that there's actually a way that I can stay anchored in this illness and not feel like I'm just bobbing around without an oar. Here goes the metaphor again. This is a how-to. It's practical. It's so straightforward and easy, and it's positive without being toxically positive. It is hopefully the kind of book that you feel comfortable giving to someone with a new diagnosis without saying, oh, guess what? You're all doom and gloom. It's not full of doom and gloom. It's full of hope and skills and advice and stories. And I honestly, people say, oh, a book is not going to change anything. But for me and for CN, we feel so good that this is finally concretized in something like a book or our podcast, so that if we disappear, we haven't just kept all of this information to ourselves. It's a way of just putting out there everything we've learned in my career and his career, and offering it to citizens and telling citizens, you can do this, we can do this. It doesn't have to be as bad, as scary. Being a patient and a caregiver is nothing anyone prepares for. The healthcare system is a foreign system. We don't get trained to interact with the healthcare system, with people in white coats and swinging stethoscopes, speaking Latin and Greek words. It is not fair if you only get one chance not to know how to prepare to be in a role of someone who has an illness or caring for someone with a serious illness. So it is a how-to, and it's a gift, I hope, to people.
Yes. Oh, it is a great gift. Thank you. Thank you for this gift. And I do want to come back to a question that we had in the chat, Sammy. We have a question about when a patient, the patient who has a life-limiting diagnosis has a cognitive impairment that makes understanding their own healthcare situation impossible, how can these principles and keys be implemented? How can people help to give that sense of control to someone with a cognitive impairment?
Yeah, it's a really good question. So I'm thinking of a couple things. I'm thinking with dementia. Okay. So there's, millions and millions of people with dementia. Well, wouldn't it be nice to know that if I was diagnosed with dementia, but I still had some capacity cognitively, that I would be offered a roadmap. I could be involved in knowing what my illness is going to look like, that I could prepare and help with my family's preparation, because all of us know what dementia is going to bring for me. That if people start at the beginning of their illness, before they are so far into it that cognition doesn't allow them to participate in decision making, it smells of advanced care planning discussions. And but we really can't, but we can have those more specifically around an illness if we know when we get something like dementia what we need to talk about. My memory is going to get worse. My ability to communicate is likely going to get worse. I will have trouble, with higher level cognition and decision making. And, people have the right to know if their particular illness comes with cognitive decline. With Parkinson's, that can be an issue as well. With certain other illnesses, it can be. So you have the right to ask at the beginning of an illness, is this the kind of illness that's going to affect my cognition? And if so, I want to know everything about this illness and start planning ahead. And then for people who have intellectual disabilities, usually those people, not always, have a natural crew wrapped around them. People who have advocated for that person their entire life. And we need to respect the relationship between the family and the patient with the illness. And the family becomes the de facto, decision makers, because hopefully they've always acted in the best for the patient their entire life. So we need to respect that the patient knows this person well, that it's not what we want for the person. The family knows the person well. So it is, and we have to have a better tools as healthcare providers to assess what capacity a person has to understand their illness and be able to communicate it at their level. And I don't think we do that assessment well. You have capacity or you don't have capacity.
Yeah, it's terrible.
Maybe there's a gray area that this person has some capacity to understand some bits and pieces.
Yes, in British Columbia, the supported decision-making arrangements that are in place are really respond, I think, to that gray area that affects many, many, many people who have an Alzheimer's or dementia diagnosis, but also in disability. Kim posted in the chat a question about when someone is born without the capacity to understand one's own life-limiting disease. We have to enact these strategies ourselves, don't we, on behalf of a patient and act as a proxy.
Yeah, exactly. And again, hopefully that person has someone, because I'm aware not everyone does, but yeah, you're right.
Yeah. And we've only have a couple of minutes left, but just in the last few minutes, I wonder if you on your Instagram page, you have the best little, quick posts about myth busting. what are the myths dying that, and, you know, having this critical illness and whatever might be in our own minds about what death is, or dying rather is. What are those myths? Can you just list a couple and bust them for us?
Yeah, sure. Well, that dying is automatically painful is the first one that always comes to mind, that every human thinks that dying is painful. And it's not. The dying process itself, what we are pre-programmed to physiologically do when our body is triggered to go down that road, is not fraught with pain. Certain illnesses can have pain, but not always. But the dying process itself is not inherently painful. So if a person has not had pain in their illness, first, second, third, fourth chapters, then they're unlikely to suddenly have pain at the end. So not all dying is painful. The other one is what I already said, is that dying is not a light switch. You don't just stay stable and then suddenly, unless you're struck by lightning, drop off and become dead. Dying is a chapter in life that has very typical pattern to it. And if we're in tune to it, we can pick up on it usually months before someone is dead. And people have a right to know that there is a downward slope, and it's got very specific features that you can know about. Other myths are that, you know, that people don't die unless they're old. I mean, of course, people can die at any age. What else are some good ones?
Well, I think that dying, the process of dying is automatically sad and tragic. I know people personally who have died. My friend recently, my friend Vicky Kamak, who is a great leader, Order of Canada, in the disability movement, and she died recently of pancreatic cancer. Her celebration of life is this weekend, and this coming weekend. And, you know, she recorded in the form of letters to friends, her dying experience. And honestly, it was beautiful, beautiful,
Yeah.
profoundly spiritual, and surrounded, you know, just by love. And she gave a lot of love. I think that, I guess, we shouldn't have any set expectations, maybe, about what it's going to be like for us. I remember having no idea what the birth of my kids was going to be like. I don't know why we think we know what dying is.
I too, Donna, have seen amazing, beautiful moments in the face of dying. In the last year of life, I've seen incredible things happen for people and their families. And this is why it's important to socialize these messages, because especially with more countries and states legalizing medical assistance in dying with no judgment, it is, for me, become a crisis that people could choose to end their life when they may not even know what natural dying looks like. But we know they're scared of it. We know that they have myths and misconceptions about it. And so it's important for people to know all their options, including what does natural dying look like and what does it not look like? And what does it offer you as a person? What does it offer your family? So that if someone is interested in a medically assisted death, that they don't only get information about that. The person who's giving them that information should also paint an accurate picture of what that person's natural dying process will look like from whatever illness they have. And then and only then can a person really make informed decision making about the means by which they want to die.
Thank you so much. We did have a question about MAID in the chat, and I want to mention also that this is a topic I would like to do a whole separate webinar on. It's a topic that interests me hugely. So we will revisit medical assistance in dying in another webinar. Hopefully next year I'll be able to do that. Sammy, I want to thank you so much for this fascinating conversation. It's so illuminating and it's so hopeful. It's hopeful to me personally as the mother of a 34-year-old man who has been on palliative care since 2005. He didn't die, but we're still on palliative care and getting great care through that service. You know, I just really encourage people to visit your website on at the Waiting Room Revolution. You will find all the keys there, and also to pre-order your book, which I believe comes out on September 19th. Is that right?
It's been the longest wait ever. Yeah, September 19th. Yeah, but you can pre-order it now if you're interested, and people should definitely buy your book too, Donna.
Oh, thank you so much. Thank you, everyone, and have a great day. Tell your friends about Caregiving Essentials course, our free course for family caregivers here at McMaster Continuing Education, and tell everyone about the YouTube channel where you'll find all of the previous webinars as well. Thank you, Sammy.